Good evening. Welcome to part 1 of the SCRN review course. This is a generalized stroke care lecture. My name is Jill Peoples. I'm a certified neuroscience registered nurse. I work in the intensive care unit neuroscience at Lehigh Valley Health Network in Allentown, PA. We're a comprehensive stroke center. This is the first lecture as you prepare to take the SCRN exam. This one is fairly general. Subsequent lectures will be more detailed. At the end of this lecture, I talk about the NIH stroke scale. Prior to your next lecture, you'll be required to do some online training on the National Institute of Health stroke scale. It's a free program and you can practice using the stroke scale and you can get certified. So that's a requirement for this class and it's a prerequisite for the next class. And you will hear it mentioned in this lecture, but the best way to really familiarize yourself with it is to apply it with that computer-based training program. So objectives for this lecture, we're going to identify 5 symptoms of stroke. We're going to differentiate between hemorrhagic and ischemic strokes. You should be able to articulate 3 aspects of the stroke care administered by a nurse for a patient who has received IV TPA. Should also be able to describe 3 aspects of specific care of a patient with a hemorrhagic stroke, also known as an intracranial hemorrhage. You should be able to demonstrate 4 interventions that a stroke primary nurse in the ER caring for a stroke patient will have to do. And the last objective is personal. I encourage you to be reflective and think of one thing personally and one thing professionally that achieving SCRN certification will do for your own advancement. Okay, so a little bit of background on the SCRN. It's a relatively new certification. It was developed in 2013. It was developed by the American Board of Neuroscience Nursing, and it really came about as a way to recognize expert care given by stroke nurses. It is a generalist exam. The focus is on knowledge, interpretation, and problem solving. The SCRN is applicable for any nurse who takes care of stroke patients, whether that be in the pre-hospital setting, emergency room, ICU, med-surg, research, education, advanced practice. Anyone who takes care of stroke patients can benefit from SCRN certification. Requirement is 2 years of experience in stroke nursing prior to being able to sit for the exam. Just some facts about stroke to get us started. I apologize if this is hard to see. Stroke is a time-sensitive medical emergency. It is the 5th leading cause of death in the U.S., and it is also the leading cause of disability. Strokes are complex. They present differently. Different strokes will present differently in different individuals, and different types of strokes have different treatment protocols. So persons caring for strokes, whether they be nurses or other members of the interdisciplinary team, really need to have specialized knowledge in order to provide safe and timely care for stroke patients and to get the best outcomes. This is BFAST. You might be more familiar with the acronym FAST. B was added recently. The BE stands for some more atypical stroke symptoms, B for balance, E for eyes. It's an acronym you can remember and you can spread to your loved ones and people in the community. These symptoms are early basic symptoms of stroke, and if anyone experiences sudden onset of these symptoms, they need to call 911. The B is for balance, E is for eye, sudden loss of vision, loss of peripheral vision. F is for face, facial droop, facial paralysis, A is for arms. It signifies unilateral loss of motor movement. So if you lift your arms up and one of them becomes flaccid. S is for speech, trouble speaking, slurred speech, thick, garbled speech, also being mute or being unable to understand speech. That's a sign of a stroke. And time is of the essence. So any sudden onset symptoms of stroke, you want to call 911. And it's very important to call 911, even if the nearest hospital is 5 minutes away by car, because by initiating EMS, they can contact the local hospital, make sure that you're transported to the nearest stroke center, and they can communicate with the hospital on the way. And when the patient arrives at the ER, they're able to get the appropriate care in a timely fashion. So time is brain. 2 million neurons are lost for every minute of stroke. So it's really ultra important that we provide stroke care in an expert and timely fashion. The best chances of recovery are the quicker that the patient is treated. So stroke is a problem with the blood vessels. There are two main kinds. The most common is an ischemic stroke. That's about 85% of strokes. Other type is hemorrhagic, which encompasses 15% of strokes. Both types can present with the same symptoms or similar symptoms. So the only way to determine which type of stroke it is a CAT scan of the head or an MRI. I have this crude picture, if you can see here. This image, it shows a stroke caused by a blood clot. And then this one, so that's an ischemic stroke. This is a hemorrhagic stroke. The stroke is caused by a burst blood vessel in the brain tissue. We also have to know about transient ischemic attacks, or TIAs. TIAs are transient. They're stroke symptoms that last usually between 15 minutes and an hour. The stroke symptoms completely resolve. However, this is still a medical emergency. The patient needs to get checked out because it could be a warning sign that a stroke is about to occur. So for these ischemic stroke, it can be caused by a thrombus or an embolus. A thrombus is if there is a clot in the artery in the brain that blocks blood flow and limits perfusion to the brain. An embolus is simply if the clot or the plaque forms in another part of the body and travels to the brain. They'll both cause an ischemic stroke. Hemorrhagic stroke, typically we're dealing with intracranial hemorrhages for the purposes of this lecture. There's also subarachnoid hemorrhage, which is considered an hemorrhagic stroke. Those are many times caused by ruptured aneurysms, and they're kind of an entity unto themselves. So for the focus of this lecture, we're going to be focused on intracranial hemorrhages. But it's bleeding inside the brain or in the brain tissue. Subarachnoid hemorrhage is bleeding in the subarachnoid space, which is between the brain and the skull. So there's different treatments for different types of strokes. For the ischemic stroke, it's time sensitive. So if it's less than 3 hours before the onset of stroke symptoms, an ischemic stroke patient can be treated with IV TPA. That's a clot busting medication, but it's time limited. This drug was initially introduced in 1995, and it had a strict window of 3 hours. As due to scientific advancement and the increased research, they have increased the window up to 4.5 hours for certain patients. But that's a very thorough risk-benefit analysis and also conversation with the patient and the family about the risks. Other treatments for an ischemic stroke is mechanical clot retrieval, also called a thrombectomy. That is when a catheter is inserted into an arterial blood vessel in the groin, and the clot is retrieved with a mechanical intervention device. Other treatments, we can use blood thinners and induced hypertension sometimes. Sometimes ischemic stroke patients require enhanced blood flow to the brain. So we actually manage their blood pressure at a much higher level than usual. And these patients might also require flat bed rest. So that would be induced hypertension. So the IV-TPA, for patients who qualify for the IV-TPA, it's also known as its brand name, which is Alteplase. It's time limited. Before receiving IV-TPA, a patient must have a non-contrast CAT scan of the head, and that is done to rule out intracranial hemorrhage. An acute stroke might not be seen on that initial CAT scan, but it is absolutely imperative that a patient receives a CAT scan before TPA is administered. One of the side effects of TPA is anaphylaxis. So that's something, it's rare, but it can occur. So any clinician caring for a patient who's received IV TPA, you want to just be aware that anaphylaxis can occur. You want to get a good health history on these patients. Talk to the patient if they can talk to the family, look at the medical record. You want to make sure they're not taking any blood thinners, haven't had any recent trauma, recent surgery, recent internal bleeding, because these would be contraindicators for TPA. So a little bit about contraindications, recent stroke, recent myocardial infarction, pregnancy. Another contraindication for IV-TPA is a rapidly improving stroke symptoms and minimal deficits, because these patients have shown to improve and do really well on their own without, the added risk of TPA. Nursing assessments. Nursing assessments for IV-TPA. These patients should be cared for in an ICU setting with stroke-trained nurses or on a dedicated stroke unit. It's time intensive. Patients require frequent vital signs every 15 minutes for 2 hours, and frequent vital signs continue for 24 hours. Blood pressure needs to be closely managed. Treated for systolically above 185, diastolically above 110. Tight blood pressure control has been shown to decrease the risk of bleeding post-TPA. Post-TPA, patients also require frequent neurological exams, same as vital signs every 15 minutes for the first 2 hours. Continuing frequent neuro checks continuing 24 hours after the TPA was administered. Patients also need a CAT scan 24 hours or an MRI 24 hours after TPA. That's to determine that there was no bleeding event. And typically these patients are going to require blood thinners, aspirin, maybe Plavix in the future. And after that CAT scan at the 24-hour mark, if that shows no blood, then it's safe to start blood thinners with these patients. And we'll cover that more in subsequent lectures. So in addition to TPA, there is mechanical clot retrieval, endovascular interventions. These can only be done at comprehensive stroke centers. So TPA can be given sometimes at community hospitals in consult with a telemedicine neurologist. But if a patient is going to have a mechanical clot retrieval, that needs to be done at a comprehensive stroke center. So that's a rationale for patients to be transferred to comprehensive stroke centers. In this instance, a catheter is threaded through the femoral artery, usually up into the brain, and large clots are able to be retrieved with these specialized devices. The devices have improved over the years. The newest devices have been correlated with better outcomes and less disability for patients undergoing the thrombectomy. Thrombectomy treatment is time sensitive, but the window can extend up to 24 hours. So if somebody was last seen normal before they went to sleep at 9 p.m. and they wake up at 6 in the morning with stroke symptoms, they would not be eligible for IV TPA, but they might be eligible for a mechanical thrombectomy. Additionally, a patient can receive both. They can receive IV-TPA, and also if the neurologist team determines that a mechanical thrombectomy could help, they can have both therapies. The nursing care post thrombectomy is similar with TPA, frequent neuroassessments, frequent vital signs. Additionally, you check the groin site, the sheath site for a developing hematoma, and you're doing neurovascular checks in addition to the neuro and the vital signs. Typically, the patient will have to lie flat for about 6 hours post-procedure. Sometimes these patients need anesthesia for the thrombectomy, so then you're providing post-anesthesia care as well to these patients. So typically, the thrombectomies are done at comprehensive stroke centers where there's a neuro team available 24/7. This includes a stroke neurologist, usually a neurocritical care doctor, also the availability of a neuro radiologist, an interventional radiologist, that's who would do this procedure, and then neurosurgery availability if needed. Other treatments for ischemic stroke would be anticoagulation. Sometimes these patients will be on a heparin drip, and induced hypertension. I kind of mentioned that a little bit earlier. The take-home point is even if the patient did not receive TPA or a mechanical thrombectomy, if they have an acute stroke, they still require close neurological monitoring. You want to pick up on any changes, and that might tell you if the stroke is getting bigger, the patient's having swelling, or something is going on. So you want to be very in tune with these patients so you can pick up subtle changes, communicate them to the stroke neurologist. They might need a CAT scan or an MRI. They might need to be managed at a higher blood pressure. You might need to start a heparin drip. So it's really important that you do close neurological assessments and you have the proper training. Moving on to the hemorrhagic stroke. As I said, hemorrhagic strokes are more rare, about 15% of strokes. You want to identify the cause of the bleeding. If this stroke patient presents in the ER and they're going to go for a CAT scan, and that hemorrhage is going to be visible on CAT scan right away. And then we want to determine the cause. So typically these patients will have either a CAT scan angiogram, maybe an MRI, MRA, or MRV, trying to determine what caused the bleeding. A lot of times these are caused by hypertension, high blood pressure. Sometimes illicit drug use will cause an ICH if the blood vessels constrict and then burst. Age, because the blood vessels become more fragile with age. And cerebral amyloid angiopathy, that's one disease process that puts patients at high risk for ICH. Other causes, you might see some arterial vascular malformations. And sometimes if people take warfarin or other anticoagulants, but particularly warfarin, and have a super therapeutic INR, that might cause intracranial bleeding. If that's the case, the warfarin effects need to be reversed, and typically they'll get vitamin K, they'll get prothrombin, and they'll get fresh frozen plasma. Treatments for hemorrhagic stroke, these patients require close neurological monitoring. They should be in an ICU or dedicated stroke unit. It's ideal that there is a neurosurgery team available in case they developed extension of the bleeding or increased intracranial pressure. These patients could require an external shunt called a ventriculostomy to be placed, or sometimes emergency evacuation of the hematoma, or a decompression of the brain if the bleed is that big. So you want to monitor for signs of rebleeding and increased intracranial pressure, and of course communicate those findings promptly. Another thing I want to talk about is stroke mimics. They're not strokes, they're not cerebral vascular in nature, but these are conditions that can mimic the signs of a stroke. So hypoglycemia is a big one. It's really important if you're taking care of a patient who's displaying symptoms of an acute stroke. You want to do a finger stick. Don't wait for the BMP to result. You want to do a finger stick. Make sure they're not hypoglycemic, because that can definitely mimic some of the symptoms of a stroke. Other stroke mimics: complex migraines, epilepsy, seizures, a postictal state that mimics a stroke. That's the most common stroke mimic. Can also be caused by hepatic encephalopathy, or sometimes a brain tumor or a type of brain abscess can cause the stroke mimics. So we're going to move on to talking about different types of stroke centers. There's primary stroke centers and comprehensive stroke centers. Primary stroke centers can triage a patient with acute stroke symptoms. Usually they'll have a partnership with a larger hospital complex, maybe a comprehensive stroke center, and they'll be able to do telemedicine. So a neurologist from a remote site can access this patient by video, do a full neuro assessment, health history, talk to the patient, talk to the family, make recommendations, advise on TPA dosing, facilitate transfer to a comprehensive stroke center. If a patient is pretty straightforward without a lot of medical history, they can receive TPA or receive treatment for their acute stroke without being transferred to a comprehensive stroke center. For patients who are more complex, who might have a lot of comorbidities, might be a candidate for a mechanical intervention, or are at high risk for complications, a lot of times the intensivist will recommend transfer to a comprehensive stroke center. Comprehensive stroke centers, in addition to having the capability to do the neurovascular interventions, the mechanical thrombectomy, they also have a dedicated stroke team. So there will be a stroke neurologist available 24 hours a day, 7 days a week. Same thing with a neurosurgeon availability, and the availability of a neurointerventional radiologist. You also have dedicated stroke nurses, dedicated rehab teams, dedicated stroke teams. So we're going to talk about a stroke alert or a code stroke. That's the process of activating the stroke team. If a patient has stroke-like symptoms in the community and they arrive by ambulance, the EMS will call ahead and activate the stroke team. If the nurse in the hospital or a clinician in the hospital observes patients with the signs of an acute stroke, they'll activate the stroke team as well. The goal is to get a head CT within 15 minutes. That CAT scan should be read immediately by the neurologist and the radiologist, and they're going to decide on treatment options. Door to needle times, 45 minutes is ideal. I think the goal is maybe an hour, but you really want to be like a door to TPA time. 45 minutes is pretty much the standard nowadays. Just want to talk a little bit about the role of the emergency department nurse in the code stroke situation, because there's certain responsibilities that he or she absolutely needs to make happen. As I said, you need to obtain a stat finger stick of blood glucose to make sure the patient's not hypoglycemic. You also want to communicate to the CAT scan department that you're bringing this acute stroke patient over for a CAT scan, and it needs to be done and read stat. You want to establish IV access. They need 2 peripheral IVs if they're going to receive TPA, because you don't want one going bad and not having a backup. I also want to facilitate lab draws. You don't have to do all these skills, but you need to be able to delegate. So you want to do a CBC, a chemistry, coags. It's a good idea to do troponins. EKG is another good idea. And you, of course, want to make sure that, the stroke team is arriving in a timely fashion. Another thing the stroke nurse will do is administer an NIH stroke scale. There's, especially in smaller hospitals without dedicated stroke teams, there's emerging field of research and application on nurse-driven protocols. And that is where the nurse is the initiator of these institutional protocols for stroke patients, doing all those things that I just mentioned. And this is a field where SCRNs are invaluable. So the SCRN works closely with the telemedicine doc, makes recommendations to either treat the stroke patient in their facility or transfer them to a comprehensive stroke center. And studies have shown that there is a reduction in door to TPA time, and also more rigorous following of institutional-based protocols in a timely fashion when these nurse-driven protocols are initiated. So just really, it's the case for the stroke certified RN really knows no bounds. I mean, these nurses are experts in taking care of stroke patients, identifying stroke symptoms, making sure that the interventions are carried off safely in a timely fashion, documenting and reporting complications. So SCRNs consistently recognize stroke symptoms, activate stroke processes, follow institutional protocols, and provide timely care. There's not a ton of research. It's a newer certification. There is a study in a 2019 edition of the Journal of Neuroscience Nursing that talks about how SCRNs in an institution in Texas had quicker door to treatment times and also better compliance with institutional-based protocols. It's definitely a field where more research is needed. And as the specialty grows and SCRNs are used in these acute stroke settings, hopefully that body of research can develop. Just briefly going to talk about the National Institute of Health Stroke Scale. You'll be doing the computer-based module on that. But this is an evidence-based tool for assessing an ischemic stroke, and it's standardized. It allows for communication between clinicians and providers. The higher score correlates with a bigger stroke and probably a worse outcome. And formal training is necessary to ensure that it's used reliably. And the best way to get good at the NIH stroke scale is to just practice like any skill. And these computer modules are great because you can do them over and over. They're modeled on real scenarios. They use real actor clinicians and patients, and you can do them as much as you want. And you get CEUs for doing it, which is great. You can't beat that. Another thing with the NIH is it's a mandatory assessment tool in stroke centers in the U.S., so any hospital that provides care to acute stroke patients, clinicians are mandated to communicate and document using the NIH stroke scale. And I thought that was pretty interesting. It's done because it provides a common language and a way for people to communicate. And I think that's really important, especially given the complexities of the stroke population. This is an NIH stroke scale pocket guide. I have the link here. You can download it. It's invaluable. I carry it with me in my nurse toolkit at all times, and it's always good to have a refresher. And just the use of scales for ongoing assessments. It's just really important method for measuring neuro changes, tracking trends, prognostication. So there's a lot of different scales that you can use that we're going to learn about in this course. For our purposes, the NIH stroke scale is going to be our next our venture. So, but used in combination with comprehensive assessments and, diagnostic imaging, that's really a good way to provide the best care for stroke patients. So I thank you so much for your time. This is my reference list if you're interested. If you have any questions, feel free to contact me. Thank you so much. I'll see you next time. Bye.